Welcome, friends, brothers, colleagues from the medical career, and people who are interested in medicine. This is your channel Consultor Clinics. Today we will talk about brain abscess. In the previous video we talked about corneal abrasion. I'll leave you the link in the description so you can go see it in case you have not seen it. I also urge you that if you want to deepen this topic, you can consult your medical guide texts. Without more to say, we can continue. Definitions. A brain abscess is a focal intracerebral infection that begins as a localized area of cerebritis and evolves into a collection of pus surrounded by a well-vascularized capsule. If we read this concept carefully, we see that it speaks of one of the characteristics. This pus is surrounded by a capsule, that is, it is a bag of pus. Epidemiology. Quite uncommon. Frequency 2% compared to brain tumors, appears at any age. Maximum indecency in preteens or middle-aged people. The most common underlying infection is contiguous spread from the sinuses, middle ear, and teeth. The headache is usually located on the side of the abscess and its onset can be gradual or sudden in 70% of cases. Symptoms and signs. Classic triad. Headache, fever and focal neurological deficiency in 50% of cases. Fever appears in only 50% of patients. Focal neurological findings, seizures, hemiparesis, aphasia, ataxia, occur in 30,150% of cases. Papillary edema occurs only in 25% of cases. Presence of adjacent infections, dental abscess, otitis media, and sinusitis, can be a clue to the underlying diagnosis and should be sought when a case is suspected. The temporal evolution from the appearance of the symptoms to the presentation ranges from hours for formal cases to more than a month. 75% appear in the first weeks. The nonspecific presentation of a brain abscess requires a high level of suspicion from all clinicians. Etiology. Brain abscesses originate from contiguous infections. Hematogenous spread from a distant site. Probable sources of brain abscess: contiguous focus or primary infection, 55% of all brain abscess. Paranasal sinuses. It affects the frontal lobe, caused by intracraneal bacteroides, hemophilus and fusobacterium spp. Otitis media/mastoiditis. They affect the temporal lobe and cerebellum, caused by streptococcus, enterobacterial bacteroides and pseudomonas spp. Sepsis of dental origin. Affects the frontal lobe, and is caused by a mixture of fusobacterium, bacteroides and streptococcus spp. Penetrating head trauma. The location of the abscess depends on the location of the wound, caused by Staphylococcus aureus, Clostridium spp, Enterobacterial. Postoperative. Caused by Staphylococcus epidermidis and S. aureus, Enterobacteria and Pseudomonas. B. Hematogenous spread/remote-sided infection, 25% of all abscess. Abscesses are usually multiple, but especially in the territory of the middle cerebral artery, the responsible germs depend on the source. Congenital heart disease. Streptococcus, Hemophilus spp. Endocarditis. S. aureus, S. Gordon's urinary tract. Enterobacterial Pseudomonas intra-abdominal. Streptococcus, Enterobacteria, and anaerobes. Lung. Streptococcus, Actinomyces spp. Fusobacterium spp. Immunosuppressed host. Toxoplasma spp. Fungi, Enterobacterial Nocardia spp. Tuberculosis, Listeriosis. C. Cryogenetic, source unknown, 20% of all brain abscess. Diagnosis. Differential diagnosis. 1. Other premeningeal infections. Subdural empyema, epidural abscess, thrombophlebitis of the major ulovenous sinuses and cortical veins. 2. Embolic stroke in patients with bacterial endocarditis 3. Leaky megatic aneurysms 4. Viral encephalitis, generally secondary to herpes simplex 5. Acute hemorrhagic leukoencephalitis 6. Parasitic infections, toxoplasmosis, gynocosis, cysticercosis 7. Primary or metastatic brain tumors 8. Cerebral stroke 9. Central nervous system vasculitis 10. Chronic subdural hematoma. Assessment. Physical examination, laboratory tests and diagnostic imaging. Lab tests. White blood cells may be elevated in 60% of patients. ESR is usually elevated but can also be normal. Blood cultures are usually negative, 10% positive. Lumbar puncture is contraindicated in patients with suspected abscess, 20% die or suffer neurological deterioration. The yield of the gram stain in a material culture of the aspirate at the time of surgical drainage is almost 100%. Imaging diagnosis. MRI is the diagnostic technique of choice. It achieves better definition than CT. CT with intravenous contrast remains an excellent test. Serial CT and MRI are recommended as a follow-up to treatment response. Treatment. Effective treatment is usually done with a combination of empirical antibiotic therapy and timely resection or aspiration of the abscess. Acute treatment. There is evidence of edema or mass effect. It is essential to treat intracranial hypertension, includes hyperventilation of patients undergoing mechanical ventilation, dexamethasone and mannitol. Medical treatment never replaces surgical intervention to alleviate surgical hypertension. Neurological deterioration often requires surgery. Corticosteroids should be limited in patients with severe cerebral edema or midline displacement. Medical treatment. If the abscess measures less than 2.5 cm in a patient is neurologically stable and conscious, biotherapy can be started and wait. Empirical antibiotics are chosen for location of the abscess, suspicion of primary origin, presence of single or multiple abscess, basic medical disorders of the patient, HIV, immunosuppression, empirical antimicrobial selection, primary infection or contiguous source, otitis media/mastoiditis, sinusitis, dental infection, third-generation cephalosporin, cefataxime 2g every 6 hours 4, or ceftriaxone 2g every 12 hours 4, plus metronidazole 7.5 mg/kg every 6 hours 4, or 15 mg/kg every 12 hours 4. Dental infection. Penicillin G 1.2 million units every 6 hours plus metronidazole. Head trauma or after surgery. Third-generation cephalosporin plus metronidazole and nafcillin or vancomycin 1g every 12 hours 4. With vancomycin it should be monitored that it is given slowly to avoid retinitis. Hematogenous seeding, congenital heart disease, endocarditis, urinary infection, lung, intra-abdominal. Nafcillin or vancomycin 1g every 12 H4 root plus metronidazole plus third-generation cephalosporin. The duration of antibiotic therapy is not clear since it is variable. Most authors recommend parenteral treatment for 4 to 8 weeks with repetition of radiological studies to ensure that the treatment is adequate. It is suggested to carry out radiological studies every week during the first 2 weeks of treatment and then every 2 weeks until the antibiotic therapy is finished, and then every 2 to 4 months for 1 year, to control relapses of the disease. Surgical treatment. 2 indications. Collect samples for culture and sensitivity. Reduce the mass effect. Stereotaxic biopsy or aspiration of the abscess if possible surgically. It is essential to choose the targeted antibiotic. The time and type of surgery depends on primary source of infection, number and location of abscess, whether the procedure is diagnostic or therapeutic, neurological status of the patient, forecast and referral, consideration of early diagnosis, early initiation of appropriate antibiotic therapy, and advanced radiological studies have reduced mortality secondary to brain abscess from 40,180% in the pre-antibiotic era to 10,120% today. Morbidity usually translates into persistent neurological sequelae, seizures, intellectual or behavioral disturbances, motor deficiencies, which affect 20,160% of patients. It is obliged to consult the neurosurgeon. Thank you very much for watching the video. Next video and topic will be spinal epidural abscess, ESA. I will leave you in the description my personal blog, or I will be plugging this in all the slides that I explain in my channel. Subscribe and like. Greetings to all.